Okay, good evening, one and all. This is Dr. Sandeep Karunakaran. I am a consultant in IVF in working in India in Apollo Fertility as of now, but as a part-time measure, or rather a philanthropic effort, we try to educate the society in terms of getting better embryologists. And with that view in mind, we have started a small academy called the Life in Vitro Academy at CFHE, that is Center for Healthcare Entrepreneurship, which is located in IIT Hyderabad. As you know, IIT is one of the premier institutes which actually gives technology training to our students or from India and abroad too. One of the premier institutes in Hyderabad to give this engineering technology. We also decided to integrate a bit of IVF technology and mainly embryology into it. With this endeavor, we have started this academy, and as a sort of a philanthropic venture from our side, we have decided to do these free webinars for all so that we do have the spread of knowledge with an ethical and scientific background to whatever we are speaking. With this in mind, let me introduce Dr. Fadi Shushair. Could you get the slide up, Arun?
Yes, sir.
Dr. Fadi is one of the pillars of embryology when it comes to the Middle East, and he works in Qatar, Doha.
Sir, is it visible?
Not yet. Yeah, now it is. Yeah, he's
Yes.
the lead clinical embryologist and the scientific manager at Reproductive Medicine and IVF, Sidra Medicine, Doha, Qatar. Amongst his many accomplishments till now, I think the most important one, or one I would definitely like to highlight, is that he chairs the embryology special interest groups in the Middle East Fertility Society. And that is one of the leading embryologists are actually honored with this position. He has a lot of areas of interest, including cryobiology, in vitro maturation. But today he's going to speak about a very interesting topic, that is the technical aspects of Trophectoderm biopsy, which today we all know stands as the backbone of pre-implantation genetic testing. Not to speak about his publications, which is far and wide and plenty in nature. Let me not stand between you and this great talk. I give the stage to you, Dr. Fadi. Over to you. Thank you.
Thank you, Dr. Sandeep, and thank you, Life in Vitro Academy, for this invitation. Before I begin, I would like to take a moment to express my heartfelt condolences to all those affected by the recent tragedy in India. Our thoughts are with the victims and their families during this difficult time. Now, turning to today's topic, I will be presenting on Trophectoderm biopsy. Let me share my screen. Can you see my screen?
Yeah, it looks good, Dr. Fadi.
Okay. Also, I want to thank Dr. Alex Farghese for the invitation, who is part of Life in Vitro Academy, and hopefully we will have like more collaborations. So I'm going to talk today about mapping the intricate technical details of trophectoderm biopsy, the technicality of trophectoderm biopsy, but through an evidence-based lens. Nothing to disclose. By the end of the session, you can understand the rationale for trophectoderm biopsy versus blastomere biopsy, and we're gonna go deep into the technical aspects of trophectoderm biopsy: lab setup, equipment and materials, pre-biopsy considerations, biopsy techniques, and post-biopsy considerations also. It will not be like a brief, it's very comprehensive, and we're gonna go into details of the current evidence. Why I need to focus on trophectoderm biopsy? The rationale for focusing on trophectoderm biopsy stems from a landmark randomized paired clinical trial by Scott et al. In 2013, which clearly demonstrated the detrimental impact of cleavage stage blastomere biopsy on implantation and live birth rate. In contrast, trophectoderm biopsy performed at the blastocyst stage was shown to preserve developmental competence and clinical outcomes. As seen here in this histogram, equivalent sustained implantation rate for trophectoderm biopsy compared to a 39% relative reduction in implantation in blastomere biopsy. This pivotal evidence has shaped current practice, positioning trophectoderm biopsy as the safer and more effective approach for pre-implantation genetic testing. Beyond safety, trophectoderm biopsy offers superior diagnostic performance. Amplification failure is notably low, less than 3%. Allele dropout rates are also reduced, improving the fidelity of genetic diagnosis. Trophectoderm biopsy also yields fewer inconclusive results, so less than 5%, based on the data from the ESHRE-PGT consortium, and enables the detection of mitotic errors and mosaicisms, features not accessible with single-cell analysis. These advantages make trophectoderm biopsy not only safer, but also diagnostically more informative. Trophectoderm biopsy also demonstrates high procedural robustness. So it's a very robust approach. A large data set of around 2,500 biopsies from the data of Capalbo et al. Showed consistent and reproducible outcomes across 7 different operators, embryologists, with no significant variation in amplification failure or diagnostic outcomes. Furthermore, results from large-scale initial data set were consistent across varying blastocyst morphologies, underscoring the method's reliability and broad applicability in clinical practice. Building on its demonstrated safety, reliability, and reproducibility, trophectoderm biopsy has become the standard approach in clinical PGT. In the most recent ESHRE-PGT consortium report, the data from 2018, trophectoderm biopsy was used in nearly 100% of around 5,000 PGTA cycles, as you see in the lower histogram. The majority of these utilized whole genome amplification to enable comprehensive downstream genetic analysis, reinforcing the method's scalability and integration within advanced genomic platforms. With the clinical rationale and evidence established, let us now turn to the technical aspects of trophectoderm biopsy. Let's start with the infrastructure requirements for the biopsy lab. A dedicated area within the embryology lab is essential for performing trophectoderm biopsy, ensuring environmental conditions consistent with those for embryo handling. This is a recommendation by the ESHRE-PGT consortium. In addition, a nearby dedicated space for tubing is advised to streamline workflow and minimize exposure risks. So following infrastructure, the next essential consideration is the equipment and materials used for trophectoderm biopsy. Zona breaching, the first one is the zona breaching tool. Commonly now, in current practice, we use a laser. So laser-assisted zona drilling remains the most commonly used method, applied in approximately 80% of cycles according to the ESHRE consortium data. But now we know it's the mostly approach used, which is the laser drilling. This approach is widely adopted due to its standardization and reduced operator dependence. Emergence of laser-free techniques such as flicking method are gaining interest, but they remain less commonly used. As we see here in the table, there are several laser systems commercially available for clinical use. While we have both fixed and movable lasers are in use, there is no comparative clinical studies to determine superiority. So both of them, they perform similar, fixed or immovable laser. And we can see some of the commercially available, they have different work at different objectives, which is like preferential for ergonomics. So flexibility of work, but the outcome, it will be the same. Importantly, the operator skill, the precise system setup, and optimized pulse settings have a greater impact on the biopsy outcomes than the absolute laser power. Here we see different laser powers. Those, they are not like significant to impact which one is better for trophectoderm biopsy. So they perform the same. What's important is the operator skills and the accurate setup and the pulse settings during performance of trophectoderm biopsy. Just to mention that part of the accurate setup is the calibration of the laser. Many systems, they come with either a prepared slides, like a laser and a laser ablation of ink into the target ring, just to test that the system is precise and is accurately shooting. Or there's another practice in the lab where you take a lid of a dish, you mark it with a marker, and you try to shoot just to make sure like it's precise or it needs calibration. So there's no studies which one is better. A small take-home message: laser remains the most commonly used, safest, and elegant method for Zora drilling when required. Beyond the laser system, the micromanipulation setup plays also a critical role in trophectoderm biopsy precision. The micromanipulator type, oil-filled microinjectors offer superior motion, stability, and control compared to air-based systems, ensuring maximum precision during biopsy procedures. Now, let's move to the lab tool specifications, the pipettes. Biopsy pipettes should be selected based on embryo morphology with standard sizes ranging between 25 and 30 for the outer diameter. So you can see commercially available between 20 and 40. The standard in the textbooks is around 30 micrometer. Here we see data from a technical study showing that the biopsy pipette should be selected based on the embryo morphology. And they showed that pipettes with a narrower diameter, 20 micrometer, are recommended for H-shaped hatching and hatch blastocysts. As we see, the H-shaped, which showed more precision and a lower trauma sampling. And pipettes of higher diameter were recommended for fully expanded blastocysts and peanut-shaped hatching blastocysts to aspirate more cells. So the optimal size depends not only on blastocyst morphology, but also on the specific trophectoderm biopsy technique adopted. So in your lab, if you do a pre-hatching and you have frequently the H-shaped blastocyst, so you can use like the thinner pipettes inner diameter. The standard biopsy pipette used, also there are two models, not only the outer diameter, but also the spike. Some of them, they have the tip, they have a flat, blunt versus beveled. The standard use is the blunted ones, the flat one. Also, there's no studies showing superiority, but I'm reporting data based on the common studies. So blunt pipettes were used for pre-hatched embryos and herniating blastocysts, whether beveled pipettes for breaching zona protocols. When you breach a protocol just to avoid collapsing of the blastocysts and to have a better grip of the trophectoderm cells. As you see here on the right figure, in this protocol, they preferred using the beveled pipettes, but the standard is the blunt one. Also, no studies showing superiority. And in trophectoderm biopsy, the holding pipette may be the same as the standard ICSI size, or preferably one with a wider inner diameter, like the standard 30 micrometer inner diameter compared to the classical one used for ICSI 15 to 20. It's recommended. Why? Because a wider diameter allows the blastocysts to be gently stabilized against a broader surface, so distributing the suction evenly and reducing focal stress. So if you have the suction won't be like stressful. This minimizes the risk of blastocyst collapse and supports better control during biopsy. So holding pipette, use a standard size or wider inner diameter. In line with the importance of equipment and tool selection, the choice of media and consumables is equally critical. EPIS or MOPS buffered media are preferred over bicarbonate-based solutions to maintain pH stability outside the incubator. PVP may be also applied to coat the outside of the holding pipette and to prime the biopsy pipette interior, reducing cell adhesion to the tools and allowing smoother aspiration. As for plasticware, all plasticware, as regular in an IVF lab, should be IVF certified, including dishes, mineral oil, capillaries, stripper pipettes, and filter tips must be DNA and RNase free to prevent contamination. Finally, an important point to highlight and to emphasize, the same stringent quality control measures should be applied in standard embryology workflows, must be upheld during biopsy procedures. This includes witnessing, traceability, and quality assurance protocols. Recent debates highlights that both culture conditions and the biopsy operator may influence mitotic errors, reinforcing the need for consistent standards throughout the process. Here we see also a landmark review, a controversy in ART by Jason Swain, about questioning, debating the role of the lab in inducing aneuploidy. So use buffered media and PVP to facilitate biopsy and maintain stringent QC/QA practices. Let's continue with the equipment and materials. To maintain genomic integrity during PGT procedures, strict decontamination protocols are essential. DNA decontamination agents to wipe the surfaces should be limited to PGT preparation areas and must be ultra-low VOC formulations with minimal cytotoxicity. So, and how would we know? You need to verify the VOC profile and cytotoxicity in the MSDS, because all those detergents, they are not commonly used in embryology or embryo safe. So you need to verify the MSDS to select ultra-low VOC formulations. Always rinse thoroughly with DNA-free water, and also you can implement some practical protocols, such as performing the surface decontamination at the end of the day prior to the next day use to allow full evaporation of any residual VOCs. Also, a dedicated laminar flow hood or a dedicated clean area with UVC light is recommended. And finally, full PPE, including surgical gown, air cover, hair mask, shoe cover, and well-fitted gloves frequently changed is recommended, is mandatory. So now let's move to the technique more. Now we tackle the setup of the lab and the setup of the preparations pre-PGT. But I need to emphasize that maintaining high quality outcomes in trophectoderm biopsy also depends on operator proficiency. Preclinical training is recommended as stated by ESHRE PGT Consortium on at least 50 oocytes or 50 embryos to build foundational skills. For clinical application, supervised training should include at least 20 additional cases for practitioners with prior micromanipulation experience and 40 cases for those without. As for competency assessment, they should include evaluation of post-biopsy damage or lysis, survival following continued culture or warming, and the quality of genetic amplification outcomes. I mentioned here two figures. One of them is from the Vienna Consensus, where we have this API, successful biopsy rate of amplification, which should be more than 90%. You can use it in your practice. And also for other results, other benchmarks, there's no benchmark, but it's recommended to use the data published by the ESHRE PGT Consortium as a benchmark for your training program. So now let's move on to the bench. Another critical consideration is in ensuring diagnostic accuracy is the choice of fertilization method. Shall we select the embryos derived from ICSI or from IVF? ICSI is the recommended method for PGT, as stated by the ESHRE PGT Consortium, the recent one, as it significantly reduces the risk of contamination from the residual maternal cumulus cells or excess sperm attached to the zona pellucida. Those they could introduce technical artifacts and compromise genetic analysis. While ICSI is chosen for its technical advantages in PGT settings, studies have shown similar embryo development and euploidy rate between ICSI and conventional IVF. Newer NGS platforms and technologies, including newer bioinformatic algorithms, are increasingly designed to minimize the impact of contamination. I'll go more deep now into the technique. The biopsy method itself remains critical to both procedural efficiency and clinical outcomes. The question raises, shall we pre-hatch the embryo or not? Pre-hatching trophectoderm biopsy, where assisted hatching is performed prior to biopsy, as we see here on the left figure, is performed prior to the biopsy and be technically easier and faster. So it's around 1 minute compared to 2 minutes if we directly extract trophectoderm cells. However, its clinical impact is debated. So let's check the current evidence. There's only in the literature a single randomized controlled trial of 221 patients, and they found that although the pre-hatching group, they compared pre-hatching to the direct breaching on day 5, they had a lower blastocyst rate, lower blastulation rate. However, clinical outcomes, clinical pregnancy rate, implantation rate, live birth rate, and ploidy mosaicism rates were comparable to standard trophectoderm biopsy without hatching. In contrast, a retrospective study of around 1,500 frozen embryo transfer showed a similar lower blastulation when you pre-hatch on day 3 and a clinical outcome which is lower compared to direct ablation. These findings, so this slower blastulation with the pre-hatching, it might be, we don't know now, might be either from the hatching by itself or from disturbing embryo culture, because we're removing the embryo from culture on day 3, doing the hatching and biopsy on day 5. So pre-hatching biopsy offers a procedural precision. It's a precise and can safely be adopted if laboratory KPIs align with validated benchmarks. So in your practice, although the studies showed lower blastulation, however, the strong evidence, the RCT showed no difference in clinical outcome. Since it's a precise and easier method, if your KPIs of blastulation are within the benchmark, it can be safely adopted. Now, what's the time of hatching for herniation? When should we hatch, day 3 or day 5? Day 3 pre-hatching carries a risk of a phenomena, we call it inner cell mass incarceration, which means the inner cell mass escapes out of the hole, protrude from the opening, which is reported to be of lower incidence, around 3 to 5.5%. But if it happens, it can complicate technically the biopsy. So it's technically challenging. While robust studies found no effect on ploidy or mosaicism rate if we hatch on day 3, there's only one study reported an increase in mosaicism with pre-hatching. Also, there's no or minimal risk of monozygotic twins. It's around 2%, 0.5 to 2% risk of pre-hatching on day 3 and the risk of monozygotic twin. But we need to emphasize that recent meta-analysis reported that assisted hatching by itself increases the risk of monozygotic twins. I need to mention also a rare event that might happen. Despite it's technically challenging that the inner cell mass might escape, also hatching on day 3, we sometimes might face a risk of trapping, where it was observed a human blastocyst biopsied on day 3 in the pre-hatching protocol, and they left in culture and they got entrapped into the zona pellucida. And half of the embryo is outside the hole and half of the embryo inside the zona, and it causes degeneration of the embryo. Although it's a rare event, but it's also a risk. To mitigate the risk of such inner cell mass incarceration and trapping, several coping strategies have been proposed from mouse studies. While mouse studies provide valuable insights, direct extrapolation, we cannot directly extrapolate to humans. It's limited due to species-dependent differences in hatching incidence, embryo polarity, and hatching behavior. In mouse, they reported if this had to avoid escaping the inner cell mass from the hole, Rubino et al. Proposed to do a double laser zona drilling, a hatching on day 3 and another hatching on day 5, morning day 5. So we have 2 holes. We see here in this image. Another proposition was a day 4 hatching, not day 3 hatching, next to the area of early capitation. Those are mouse studies data. This is data reported from Mestres. It's from an abstract presented at ESHRE. And other coping methods extend incubation to get more Trophectoderm cells or breach the zona pellucida at a different site. But if we breach the zona pellucida at a different site, there's in mice, we observed in the literature a trapping risk. Here you can see old data from Montag et al. Showing that double zona opening may risk to entrap the blastocyst, leading to degeneration of the blastocyst and impair implantation. So, to sum up, if a pre-hatching biopsy approach is used, the safest strategy is to extend culture to allow more trophectoderm cells to herniate for sampling. Another approach, not hatching on day 3, some rarely reported in the literature, they hatch early day 5 and they incubate. There's a lower risk of inner cell mass incarceration. They also reported optimization in morphological assessment of the blastocyst because the blastocyst is full into its zona, and also hatching at the earlier stage showed no difference in ploidy and mosaicism rates. Now let's move to the effect of the size of the hatching point. What's the size of the hatching hole? Is it a small hole or a large hole hatching? Small hole hatching, it's recommended to be between 5 to 10 micrometer wide for easy herniation of trophectoderm cells. This size was reported in 3 papers. 5 micrometer, a small hole allows easier stretching in pulling method when we do the pulling. And also, in parallel, a large hole hatching, there's a risk of zona weakening. So if we drill a large hole, as we see here on the right scheme, there's a risk of zona weakening. There's a risk of a sudden collapse or rupture, which requires high thermal energy by the laser for dissection, and it's more invasive. Here we see like a large hole might cause a peanut-shaped blastocyst. So small hole, it's more reported, it's more safe, it's more precise. But and we need to use low pulse length duration of the laser, recommended between 150 and 180 microseconds. And some lasers, they have a predefined duration around 200. So it should be low. Why low? To be more precise, it's an extremely short, it's 200 microseconds. It means practically that the heat energy is delivered in a brief burst before thermal diffusion. So just a pulse to make it more precise. So take home message, when using a laser pre-hatch protocol, a small zona opening with low pulse duration is preferred. So that's for the pre-hatching. Now, which embryo to choose? Which embryo is the candidate to select for biopsy? Also, all data from Capalbo, from a large data set, showed no difference in diagnostic outcomes. And blastocyst morphology, as we see here in the bottom, where we see this figure, irrespective of the blastocyst morphology, even poor quality embryos. So no difference in diagnostic outcomes. Recent data show that lower quality have a lower euploidy rates, ranging between 23 to 37%. Once we control for the maternal age now. Also low quality euploid blastocyst. Here it's interesting. Data from 2014 and 2019, low quality blastocyst could obtain the same ongoing implantation rates as that of blastocyst of high morphology. And also here data from an RCT showed that a 4AA has a similar clinical outcome as a 4BC. However, Other data showed significantly lower live birth rate in poor quality euploid blastocysts. Those are data from a systematic review and meta-analysis. Here we see there's an association between live birth rate and the euploid blastocyst. Here we have a inner cell mass grade C, Trophectoderm grade C, significantly reduced live birth rate. So we know like a poor quality embryo has a lower clinical outcome, but also it's not zero. So it should not be neglected. Although having modest or sometimes conflicting clinical benefit, biopsy decision should be individualized. In patients where you have in practice few embryos or poor prognosis, biopsy of poor quality embryos may be reasonable. Also, in patients with multiple high quality embryos, it may be better to prioritize biopsy of high quality embryos and avoid investing in those with very poor prognosis. So that's in terms of blastocyst quality. So let me see here. Okay, when should we buy? And also here I need to mention day 7 blastocysts. Shall we biopsy day 7 blastocysts? Are they poor or good quality? Strong evidence showed that day 7 blastocysts have a lower euploidy rate, which is accentuated with age, and lower clinical outcome, lower sustained implantation rate, clinical pregnancy rate, and live birth rate. So despite having lower quality outcomes, they may still offer clinical value and should not be disregarded. Now the time of biopsy. There is no current optimal time for doing the biopsy. Sometimes not only biological, but also it is from an operational perspective, point of view. The biological rationale, we need to prioritize day 5 hatching and expanded blastocyst. For developmental day, some studies indicate a potentially higher euploidy rate for day 5 blastocyst, particularly with advanced maternal age. This does not consistently translate into superior clinical outcomes. So, and as for expansion level, the order of success in terms of clinical outcome is as follows. Hatching blastocyst, superior than expanded, superior than hatched, because a fully hatched blastocyst, it is very fragile and they might increase fragility post-biopsy and vitrification. So, biological rationale, prioritize day 5 hatching expanded blastocyst. Operational rationale, in clinics where you have a time-lapse incubation, where you have undisturbed observation, you have the flexibility to biopsy. But in many clinics around the world where there's no time-lapse, static culture, sometimes you need to balance practicality and efficiency. So it might be pragmatic to biopsy in those places and late day 5, just to avoid disturbing culture. So now let's move to the appropriate. Now we mentioned the quality and the time of biopsy, but what's the appropriate number of biopsy Trophectoderm cells? How much cells I need to extract? There should be always a balance between the impact on embryo competence and the conclusive diagnostic result. The ESHRE consortium guideline, they recommended 5 to 10 cells. This range provides sufficient material for robust genetic testing. As we see here in the data, large data, low diagnostic failure rates if we collect 5 to 10 cells. Also, this range does not compromise implantation potential, particularly in good quality embryos. But it's a range, 5 to 10. We believe that we need to be more conservative, like to select the lower limit, the 5 cells, for lower quality BC or less robust hatched blastocysts to minimize the potential negative impact on their implantation potential. But the question to raise, I'm mentioning now 5 to 10, but practically and objectively, how can we accurately, directly visualize and count those cells? So it's an estimation because like it's a 3D, the blastocyst. So we need to focus also through Z planes. Recent data, 2025, retrospectively analyzed the blastocyst using precise cell counting and NGS for PGTM and reported stable clinical outcomes across typical biopsy ranges up to 15. So this real-world evidence from good prognosis cases suggests that current biopsy practices do not compromise success rates within standard limits. So always aim for 5 to 10 for most blastocysts to balance diagnostic accuracy and clinical safety. Now the quality of the biopsy Trophectoderm cells. If we have a high quality or good quality Trophectoderm cells, we know that they generate excellent data, uniformity for the genetic lab and lower allele dropout rates. However, low quality Trophectoderm cells characterized by degraded DNA causes what we call background noise, which leads to several problems during the genetic analysis, including preferential amplification, high artifactual allele dropout, varied read count, spurious copy number variations, and often they result in inconclusive diagnosis. Also, damaged cells by the laser or during manipulation lead to artifactual mosaicism. So please ensure to remove delicately and properly distinguish any extruded blastomeres. Take-home message, select high quality distinct Trophectoderm cells while minimizing damage from handling and from micromanipulation. Now the method of removal. So we're stepping into all steps. I know it's comprehensive, but we're tackling all aspects. You're going to ask me, which one is better? There are two methods commonly used, the pulling and the flicking. On the left, we see the pulling method, which is where we directly aspirate and we use laser shots. So it's appropriate for partially hatched blastocysts, the figure 8 shape, potentially using 3 to 5 laser pulses. And we know from our practice, as once you do more pulses, it will increase the cell's rigidity. It will not like dislocate the cells. So it doesn't make sense to make more pulses. It will make the chunk of the tissue more rigid and more sticky. Either the flicking method on the right, we see it in the figure, it involves rubbing, aspirating and rubbing using few laser shots and rubbing to create a Trophectoderm bridge against the holding pipette, which is appropriate for more expanded or fully hatched blastocysts. And for flicking, we have two methods, with laser assistance and without laser. With laser, where we fragilize a bit the cells with the laser. And here we're going to see the evidence, pulling versus laser-assisted flicking. No specific biopsy method or number of laser pulses appear to affect mosaicism, euploidy rate, clinical outcomes. And laser-assisted flicking showed around the world a notable increase in recent adoption. So it's widely used now. No significant difference is observed between flicking and laser-assisted flicking and pulling. Thought a conservative approach is advised when using a laser. A recent trend now, which is like laser-free flicking without using few shots of laser, is considered less gentle and precise. So studies suggest it can significantly reduce the biopsy time, maintain satisfactory survival, and euploidy rates. Not only one study linked it to a high mosaicism rate. So laser-free biopsy is technically challenging for beginners and new embryologists, but for experienced practitioners who are already fast, it may offer added efficiency. However, further studies are needed to support its broader implementation. For procedural timing, how much time does it need for you to biopsy? We don't have like data, we have only a real-world benchmark from a data of Capalbo, reporting that a single trophectoderm biopsy typically should take less than 3 minutes. This is a large data set from 3 centers and from 7 operators. Now to the tubing. The key analytical points for tubing are sample quality, volume consistency, quality control, and time to tubing. Let's tackle now the sample quality. You should avoid fragmented trophectoderm cells because they contribute to background noise due to degraded DNA and they compromise downstream analysis. Also, a key point to mention, priming the pipette with PBS, which is a mixture PBS of PVP, to coat the papillary and avoid adhesion and damage of the cells, and a thorough washing. You need at least to wash, careful wash to get rid of, to remove the contaminants from the culture medium. Wash well with PBS because the culture medium, the embryo culture medium contains human serum albumin, which can interfere with the DNA amplification, which is the downstream analysis. A second point is volume consistency. Here we see a nice study from Jalas et al., published in Fertility Sterility in 2020. They see in current practice inconsistent volume of tubing in PCR tubes, which showed that even small variances in the volume, they will alter the genetic results. So higher volumes, they lead to less accurate DNA amplification and they cause analytical failures. The PGT-ESHRE consortium, they recommended a minimal final volume of 1 microliter. A third point to raise during tubing is quality control. The ESHRE PGT consortium, they recommended at least 1 negative control. Also, it is acceptable by the, as ESHRE PGT consortium stated, that it is acceptable to transfer biopsied cells to tubes with or without microscopic visualization. For sure, it's recommended to see the cells that are well tubed. And a post-tubing confirmation, expelling the capillary content into an empty dish. As the final point, time to tubing. What's the ideal time? Does it impact from biopsy to tubing? Only one study by Cole et al., it's a retrospective study, showed no association between the time lapsed from biopsy and tubing and incidence of mosaicism. So it didn't impact. And we know practically it will be like after the biopsy immediately. So achieving reliable genetic testing results hinges on meticulous sample handling, emphasizing thorough washing, consistent volume, and careful avoidance of fragmented cells. Strict QC measures like priming pipette, using negative controls, and confirming transfers are crucial for safeguarding DNA integrity and ensuring accurate downstream analysis. Last 2 points, I will not take from your time. Vitrification time. What's the optimal time post-biopsy to vitrify? It's a subject of ongoing investigation. Few studies reported vitrification time. immediate vitrification or as short as 10 to 15 minutes or less than 30 minutes post biopsy to minimize any prolonged in vitro stress. A basic science study, a mouse study, showed that time from trophectoderm biopsy to vitrification affects the developmental competence of biopsied blastocysts. And also, the majority of the literature, those they reported the time, they mentioned within 1 hour. They mentioned within 1 hour, which reflects a flexibility and practicality. They didn't were strict to which the specific time. Only a recent study in 2024 by El-Khatib et al. Showing that re-expansion grade at specifically 1 hour after biopsy. So they checked the expansion grade 1 hour after the biopsy, and they graded this level grade of re-expansion, and they reported to be significantly associated with post-warming re-expansion and live birth rate. So given the plausible predictive value of early re-expansion, thought limited evidence. So now the question is, how should clinics pragmatically weight this insight against the practical advantage of immediate vitrification? So the literature overwhelmingly advocates for rapid vitrification after blastocyst biopsy to preserve developmental competence, with emerging evidence suggesting that an embryo's ability to show early signs of re-expansion post-biopsy is a key prognostic indicator for successful outcomes. Last point, pooling. Storage. For how many weeks or months can we store? No association between time lapse, as we see here in the bottom right table, study from Cole et al. They studied the association between the time lapse from biopsy to amplification for weeks, and they showed no association with mosaicism. But we know basics of molecular biology principles. They confirm that DNA is highly stable when stored at freezing temperature. Here we see data from the International Society of Reproductive Genetics guidelines. They stated that biopsied cells in PBS should be processed as soon as possible, even when stored at -20 or -80. And I've checked some manufacturer recommendations for single-cell whole genome amplification kits. They recommend storage for at least 6 months. So we can conclude that short-term, weeks to a few months at -20 is often acceptable. Long-term, months to several years at -80 is recommended. Finally, rebiopsy. At the same year, two interesting systematic reviews and meta-analysis, and both showed that double biopsy, double vitrification, which means the embryos that they showed abnormal result, inconclusive, where the lab is obliged to thaw them, rebiopsy them, and refreeze them. That's the double approach. And there's another approach, which is the single biopsy, double vitrification, where in some labs, they vitrify all blastocysts and they schedule biopsy at a preferred time, and there they do a single biopsy. Both approaches, they led to reduced live birth rate, ongoing pregnancy rate, clinical pregnancy rate. Here we see from this meta-analysis, also the single biopsy, double vitrification showed also a significant reduction, increase in miscarriage rates. Same findings from another meta-analysis after several months infertility sterility, studying double biopsy, double vitrification showed lower live birth rate, lower clinical outcomes, and increased miscarriage rate. Why this data is interesting? It's interesting, it's relevant for patient counseling and for streamlining lab workflows. So minimizing embryo manipulation is critical due to its direct impact on clinical outcomes, a fact highly relevant for patient counseling and streamlining lab workflows. Take-home messages. To end, trophectoderm biopsy is a robust and highly reproducible technique critical for accurate PGT. Individualizing biopsy decisions based on embryo quality and patient prognosis is key to optimizing outcomes. While various biopsy methods have comparable impacts on diagnostic efficiency and clinical outcomes, the field is trending towards laser-assisted flicking. Meticulous attention to every technical detail in the IVF lab, from biopsy to sample handling, is crucial for successful and reliable PGT. And a final take-home message, we as embryologists, we can't be, as we say, Pontius Pilatus. We cannot wash our hands of accountability for outcomes if because any manipulation has impact on the clinical outcome. So we accountability for outcomes, but if we adhere to strict protocols, everything we will get like accurate and successful results. Thank you. So it's a long and comprehensive.
Thank you, Dr. Pali. To be very, I'll just put one word into the entire thing. I've been practicing IVF for about a couple of decades now, a little more than that actually. I never heard a more comprehensive lecture on embryo biopsy. I'm actually, it's an honor to have listened to you for this entire time period. And to be very frank, I had told my guys to, get ready with questions and things like that. I was even carrying a book here to write down the notes. But what actually happened is I have very few questions because
we covered everything.
Covered everything. Yeah, but I have to do a bit of question answer.
Yeah.
So I think a new kid on the block is NIPGT. So I would want your comments on that. I know there have been issues in Australia and all about NIPGT. And if at all you have some experience on blastocele fluid, uh, uh, analysis oblique spent media analysis vis-a-vis biopsy, even though we know that gold standard happens to be the trophectoderm biopsy.
Yeah, for NIP, so for the non-invasive PGT.
Correct.
When it was raised to public, we were like, the whole community was very excited because like NIPT in maternal blood was also the ultimate goal. But so the initial studies were promising, but the problem was the concordance. And because like this fluid, we have like many artifacts. Is it originally from the embryos or from the culture medium or from shedding from the embryo? Because the embryo, the blastocyst is autocorrecting. And that's one point, the origin of the free DNA. That's why to date we don't have robust data and it's not like clinically and commercially available. To even if it's commercially available in some offered by some labs, they don't report like 100% it's a euploid or aneuploid. Just they report it as prioritizing embryo. It's most likely euploid, healthy embryo. So, and from a medical legal point of view, I believe until you have an accurate test, it cannot be offered to a patient unless like you consent the patient and you tell you be realistic with them. But after, I believe, the non-invasive thing over the past decade, maybe 10 years, it was raised maybe since 2018, and still the progress, we didn't reach like a consensus.
Yeah, we haven't yet reached a consensus. Unfortunately in our field, we have a race towards embracing something new without actually being fully tested. Our time we have seen a thing called endometrial scratch, which has come in and died its own death, and now it is possibly restricted to a very few very few specific settings. Even for that matter, IMSI came in a big way, but unfortunately couldn't meet the desired goals. So, I mean, I would like the audience to take this fact across. I mean, not that I'm a big fan of any company or anything, but even NIPGT has its problems and it has not yet reached the gold standard that trophectoderm biopsy has reached. I'm pretty sure I mean, Dr. Fadi would agree to that.
Yeah, I
I
agree.
have
And the
one
point
more
is,
question. I mean,
and one point to emphasize, we need to emphasize to our colleagues, embryologists,
absolutely,
because in
especially the junior
here
ones.
there will be a lot of sometimes hypes, sometimes new trends, and sometimes we need to wait for more evidence. And we need to consider that every trial, you try it in your lab. I'm gonna try the rapid thing or NIPT. It is under experimental, so it's experimental, and you need to do it robustly with a sibling study. So we cannot like just we see like a presentation in a conference and just we adopt it in our clinical practice. And we as embryologists, we are the gatekeepers of one to use evidence-based practices. So in our practice and to save our patients, to protect our patients.
And I think one of the reasons why people have fallen to this trap is the fact that, NIPGT is a simpler thing to do. So a lot of people
Yeah,
actually fall to the fact that, oh, it's easy. Why do a PGT? Why go through the learning curve, learn the entire thing, and rather than do a NIPGT and just, give the patient the same option, or at least the companies used to drive that a lot.
yeah. Look, it might be since and how we noticed that it's still maturing and it's not like well established. We see recently over the past 1 2 years many studies where they included data from metabolomics, data from PGT, and data from AI images. So you integrate more data to get decision. Once you have like and you're studying this approach, mean that this data alone it's not sufficient.
Correct. Okay. I mean, I don't know. Okay, there's one more question from my side. I mean, I think the entire backbone of a good PGT performing clinic is a good clinical and embryology correlate. I mean, concordance or coordination, if I may use that term. Uh, do you follow any specific protocols when a patient walks in for PGT at your clinic? I mean, when does the clinician actually tell you that this patient is due for PGT? What are the steps that you take on the day of trigger? When do the clinician want feedback I mean, as to you're going ahead with the procedure, or there are fewer embryos that we have, something of that sort? I mean, could you elaborate on that?
Yeah. Look, for decision for PGT, first, once they start a treatment cycle, mainly they notify the lab if it's a PGTM case. A PGTM
Yeah, I
case,
mean,
which
let's
means
talk
after
about PGT-A.
preparation,
Yeah, I mean, M
yeah,
and SR, of course,
yeah,
is an inescapable
yeah.
need. I'm talking
Yeah,
about embryoloids. Yeah.
PGTM, they notify the lab, and we're here like in an area where we have like a lot of cases of PGTM due to consanguinity, and for PGTA, because like patients, they once they come for a treatment, they sign all consents. So the lab is notified 10 days before that we have this pool of patients, they are doing PGT because they cannot like last moment and they change their mind. So the patient, once the physician, they counsel the patient that you're a candidate for PGT, and they sign the consent in advance, and the lab will notify 1 day before the procedure. We notify the genetics lab that we have an upcoming case. Although we're a little bit conservative, so we offer PGTA for specific category of patients. For example, if you have even advanced maternal age patient and the patient who has only potential 1-2 blastocysts. So we are very realistic to this patient. Let's balance cost effectiveness. The benefit of PGTA, which is like not the discussion now, is to select and to deselect, to reduce time to pregnancy. And since already your embryos are already selected, we can transfer them untested and challenge the nature. because like now recent data are showing low mosaic, even high mosaic, even chaotic embryos, they are euploid. So that's why it's during the proper counseling for the patient, and even in our practice, the embryologists also are involved in such discussion.
Okay, I mean, that's a nice point. I mean, to have a good discussion prior to every case, even at the, I mean, generally I prefer to do it at the time of trigger so that, all the three parties who are concerned are sitting there in the same room across the table and discussing pros and cons. Another question which has come in from the audience is, I mean, do you keep biopsy pipettes of multiple sizes ready
Yeah.
at all times?
And in practice, I have two sizes. Yeah. I have the 30 and I have the 25.
Okay,
Yeah, because if you have a fully hatched blastocyst, it will be tricky. But the routine practice is the smaller size. It's more precise.
And another question which has come from the audience is about the holding pipette size. I mean, you did mention a bigger one is actually better than a smaller one.
Yeah.
Obviously, we know that, especially during flicking. I mean, I've noticed
Yeah.
that pulling is not much of an issue, but especially when it's the flicking part, I mean, it's always preferred to have a slightly bigger diameter.
Yeah. What's reported in the literature, standard is the regular one you use it for ICSI. It's the inner diameter. But some they reported in the literature that a wider diameter suction is recommended for PGTY, because once you aspirate the embryo and you have a wider suction, it's less stressful, because like not like a focal point, just from a point of handling, of ease to use.
True.
No superiority. There is no superiority.
Okay. I mean, I think that concludes the questions that I have got from the audience. Arun, any other questions from your side?
So there's one of the question from the audience. Like, what's your take regarding the use of culture media, a bicarbonate media instead of like hippies?
Yeah. Also, personally, we use like the MOPS medium, not bicarbonate. We know this discussion for ICSI, which wasn't raised for trophectoderm biopsy, was raised for ICSI, was raised maybe 2 decades, discussing the safety of HEPAs for culture or not. And it has been used, HEPAs and both, and it was safe for the over the past 20 years. Maybe last year there was a recent study showing that the medium HEPAs might interfere and change the transcriptomics of those hatched embryos. If you culture or you handle the embryos in HEPAs or not. But the standard practice is HEPAs and MOPS. But now you need to balance. Is it something it's most likely safe because it has been used over the past 30 years, HEPAs and MOPS, or exposing the embryo for drifts of pH with the bicarbonate? The embryologist will be in a rush because now he's not like focused only on the biopsy, he needs to focus on his time to do it quickly. And if you have many embryologists, how can you, as a manager, how can you track or troubleshoot the problem in this embryologist? Is it from the biopsy technique or from time delay because there was like a drift in the pH? So I believe the standard practice, HEPAs or MOPS, is safe and it has like a peace of mind.
You're muted, Arun.
Yes, sir. That answered the question.
I mean, any more questions from your side, Arun?
Nothing, sir.
Yeah, I mean, I'll take this opportunity to thank Dr. Fadi. I mean, it was the interaction was wonderful. And as I already said, I mean, I've never heard a more comprehensive lecture in the little time that I've spent in IVF. So with that, we express our gratitude from the entire academy, the staff, and the people behind the scene working towards trying to educate the population in embryology. And as I said, we'll be also putting this up in the YouTube channel that we run. Of course, we are doing baby steps, or rather embryonic steps as of now. and hopefully we can take the academy to greater heights. And with support of learned people like you, I mean, I'm pretty sure we will reach there sooner than later. Thanks.
Thank you.
I mean,
Thank you for the invitation. It's an honor for me, and you have my support. I'm always here to support all initiatives and all academies for supporting education for embryologists.
Thanks a lot. Thank you.
Thank you, sir.
Thank you. Thank you.